PKD is an inherited kidney disease. So most of the times we're going to have a family history of someone else who has PKD. It follows in generations, so that's a common scenario where PKD has been running in that family for several decades and for several generations.
So there's many ways PKD can be inherited through a family. The most common is an autosomal dominant PKD.
When we talk about autosomal dominant polycystic kidney disease, when we say dominant, that means only 50% chance of the parent to pass it to the child.
We typically have 2 copies of each of our genes. In an autosomal dominant condition, only one gene has to have something called a genetic mutation, or what we refer to as a variant, in order for someone to be at risk. And if you have an autosomal dominant PKD, you pass on only one of your genes to each of your family members. So there would be a 50% chance you pass on the gene variant, that person's now at risk for PKD, or a 50% chance you don't, and that person's back to the general population risk for PKD.
We didn't know it was in our family until my sister was pregnant with her daughter. It showed up in vitro. She had spots on her kidneys. So that's when we first heard of that diagnosis of polycystic kidney disease. Lo and behold, they're like, well, your mother needs to get tested. So my mom got tested. And then we found out my mom was positive for it. So then all the kids got tested. And so what's interesting is it hit the 2 middle girls and skipped my brother and my sister.
ARPKD is a little bit different. It's a recessive form and it's much more rare. The reason is that usually both parents are carriers of this change in the DNA and this mutation. So each of the parents are carriers, they don't have the disease, and then in this family, each child has 25% chance of having the ARPKD. Now there is another 10-20% when there's no family history, and also that's where we want to make sure that what is the type of the inheritance. Is it autosomal dominant? Is it autosomal recessive? And then use genetic testing to our advantage to make the accurate diagnosis.
Genetic testing is an important part of PKD, and we think that genetic testing over time will have more and more of a role. So right now, ADPKD is diagnosed clinically. We look at the images of the kidneys. If the kidneys are enlarged, they're symmetrically enlarged, there's a family history, then that person has PKD based on the cysts in the kidney.
My role as a genetic counselor is to provide the information to help patients understand if they want to pursue testing and if now is the right time for them. For a patient that's clinically diagnosed with PKD, it can help understand the why behind their diagnosis and be a piece of that puzzle to help understand the management and the treatment and the plan going forward. So in many individuals, we know that there's this genetic risk based off of their family history. We can't always identify the genetic factor with a genetic test, but genetic testing is going to be one piece of the puzzle to help our nephrology team understand the why and the how and the genetics behind it, which can help guide management going forward.
When my first daughter was diagnosed from that bone scan, where it was seen incidentally, a decision had to be made whether or not my second daughter would be tested. And that was a conversation she and I sat down and had together. I didn't just make that decision to have her tested. It was really a conversation we had together and made together.
When thinking about PKD as a whole, depending on the family history and the imaging, as well as that clinical story for the patient, the yield of testing can vary from patient to patient. And so it's really important for the patients to talk to a genetic counselor or a professional who understands genetics to know what the chances are of them having a genetic risk for their PKD. So if a patient has a positive result putting them at risk for PKD, there are family planning options that some people may choose to consider. Some individuals decide just to have a natural pregnancy, no genetic testing involved, and depending on what type of PKD they have, we can walk them through the understanding of the chances for that pregnancy to have PKD.
There are people who go into pregnancy knowing they have PKD. They know their mutation. They know, they've had family members who've gone through it. But there are some people that, they first realize they have it during pregnancy. So there's all this sort of runs the gamut. We see a higher risk of a condition called preeclampsia. If maybe 3 to 5% of pregnancies are complicated by preeclampsia in the general population, maybe 8 to 10 are affected in a PKD. So it's definitely not 100%, but it's something we worry about. The other risks that we can see in pregnancy is we can see a little bit of worsening of kidney function. The kidneys have to work harder. So as pregnancy goes on, you have larger blood volumes. Kidneys have to filter more for you and for baby. If people have high blood pressure going into pregnancy, we like to kind of stay on top of it and make sure we're treating it to a goal blood pressure early on. We have certain medications that we feel very confident are safe for blood pressure in pregnancy, and there are certain medications we know are not safe.
The way it's important for family planning is now we can do pre-implantation genetic testing or pre-implantation genetic diagnosis. So this is a form of in vitro fertilization where we test each embryo to see if it carries that familial PKD variant.
You have the option of testing embryos before they're implanted for this mutation. So the way that this works is you start with in vitro fertilization, IVF, and try to get embryos to the level of what we call a blastocyst.
When the embryo's about 30 to 40 cells, they'll take out one of those cells and do genetic testing on the cell to understand the genetics of that embryo, if it has PKD or if it does not. And some individuals will make decisions about what embryos to use for pregnancy going forward based off of that embryo's genetic status. This is a really personal choice and really important for people to have individualized conversations about if this is the right option for them, because there are other family planning options such as using a sperm donor or an egg donor, thinking through things like adoption, choosing not to have biological children, or going through the prenatal diagnosis process while pregnant.
I think genetic testing in PKD is very complex, and so I think as those methods are refined and made more accessible to more people, they will then in turn have the ability to think about these different testing modalities and options with in vitro fertilization, etc.
What I advise our patients is it's a very personal decision. I can give them all the information needed. We refer them to our obstetricians who specialize in pre-implantation genetic diagnosis and IVF, and they can decide what is best for them as a family. The most important thing is for our patients to understand their options and have a very good informed way of knowing all these options and then make a shared decision or a decision together with their healthcare providers.